Unfortunately, this work has not been replicated. And in the following bullets, you'll see these numbers are highly variable. In a study out of the University of Jordan, 84% of subjects were found to meet 2 out of the 5 criteria and no controls. And the Buffalo study described these abnormalities in 56% of subjects and just over 22% of controls. A study below that out of Germany, 20% of people with MS. And finally, the last bullet is the most recent data presented at ECTRIMS, where 16% of subjects with clinically isolated symptom were found to have CCSVI criteria. Okay, how's that? Good? Oh, I didn't see Mandy. Back. Okay. Don't lean in. Clinically isolated syndrome is a first event suggestive of MS. Now, if venous obstructions in the large vessels are indeed the cause of MS, then we might expect to see these obstructions before the disease starts. And at least it appears by the information I'm presenting here that this is not the case. The problem is you cannot rely on a test if it does not replicate the same findings every time you do it. And in this situation, the large variability raises concern about the usefulness of this test to detect possible venous abnormalities at this time. So what other modalities do we have? What other imaging modalities can we use to look at anatomy? Well, MRI techniques. So there have been 3 studies now presented from different countries showing that there does not appear to be any significant differences between the MRI venous findings in people with MS and controls. And venous abnormalities or variants of normal appear to exist anywhere between 20 to 50% of the population in these 3 studies, regardless of whether or not people had MS or not. And the first Canadian study is quoted here out of London. There's also some work to suggest that MRI may not be the most useful imaging tool to look at venous anatomy and physiology. And part of the problem is the dynamic nature of veins. So while you're sitting there, if you look at the back of your hand, you may see that your vein is puffed out, nice and puffy. It's been sitting on your lap. And when you hold your hand above your head for a few moments, that vein collapses, and you no longer see that it is puffy. And this is normal physiology of veins. The same is true with veins in your neck or in other places of the body. When you change position or when you change your breathing pattern, the vein shape also changes. So we get back to the question then, is there abnormal circulation in MS or not? And Dr. Zamboni was the first to ask the question or to suggest that there may be abnormal circulation in the large vessels that drain the blood from the brain and spinal cord. But in fact, maybe we need to take a step back further. Maybe we need to look at circulation in general in the MS vein. And Professor Zurlink from the University of Saskatchewan published an article in 1998 suggesting that a problem with blood flow delivery might lead to inflammation or stimulate inflammation as we see in MS. There were also some more recent posters presented at ECTRIMS suggesting the same. A study using MRI showing that less blood flow was observed in and around MS lesions. We also may need to look at the small veins. Some work out of the Buffalo group is showing that the periventricular veins, the very small veins around the ventricle, appear to be less visible in people with MS compared to people without MS. And finally, this last study was an ultrasound study attempting to find the same findings that Dr. Zamboni had proposed and was unable to do so. In this study, they found no venous abnormalities by ultrasound, but they did find that in people with MS compared to people without MS, there was increased flow through the internal jugulars when a person moved from the lying position to the upright position. And this is the opposite to what we might expect if the CCSVI theory holds true. So what do all these observations mean? What they mean to me is that there may be something to do with abnormal blood flow that warrants further investigation in MS. It may be important. So what are the next steps? So this is the physicist on our research team, and I like it because I think it shows our determination and our patience, and it also shows that in fact the scientific process to do things properly indeed does take time. So we are involved, as was mentioned earlier, in the BC SASC study, and with this study we intend to compare 3 different imaging modalities involving catheter venography, ultrasound, and MRI in both people with MS and without MS. And we look forward to learning through this work. Currently, the recommendation from the scientific community and the medical community for the majority is that venous balloon angioplasty and stents are not recommended for the treatment of MS. Now, in history and today, people with disease have always sought alternate treatments that are not currently provided by the standard of care in the healthcare system within which we live. And this is perhaps for a variety of reasons that are more dear to you and that you understand most. I like to be close, sorry. But in order for treatment to be available through the standard of care in our healthcare system, research in evidence-based medicine must support that it helps patients. And this process is beginning. So the first open label study was published, as you know, by Dr. Zamboni in 2009. Unfortunately, though, this is an open label study without a control group, and it does not provide the evidence needed to recommend this treatment as the standard of care at this time in Canada. And I hope it's not review, but I thought I would take a moment just to capture the results of that preliminary study. There were 10 primary progressive patients, 20 secondary progressive MA patients, 35 relapsing remitting patients, and 16 out of the 65 were on no treatment. So most of them were on one of the treatments that you heard about already earlier this morning. And importantly, all the subjects involved in the trial could walk either with or without an aid. And what were the conclusions from that first trial? Well, unfortunately, restenosis was described in almost half of the patients who were treated with balloon angioplasty of the jugulars, and a minority, 4% of the patients who had balloon angioplasty in the esophagus. There were no significant improvements in disability in the secondary progressive or the primary progressive subgroups, that was 20 and 10 patients at 18 months follow-up. And disability was measured by an outcome that includes a measurement of hand function, walking function, and cognitive function. I should mention that quality of life did improve in that trial in patients with relapsing remitting MS and the 10 with primary progressive MS. And quality of life is a measure that a patient reports with respect to how they feel, both their mental quality of life and physical quality of life. Quality of life is exceptionally important. Unfortunately, though, it's very subjective, and without a control group, we cannot conclude that quality of life improved because of the interventional treatment or to do with some other factor that was not controlled for in the trial. And there were some other limitations with respect to the findings. The fact that disability improved only in the relapsing remitting subjects at 1 year in the abstract and actually 18 months presented in the text of the paper limits the findings to only this group at this time. The relapsing remitting subjects were also on disease modifying therapy, and so we do not know if the treatment effects were related to perhaps the disease modifying therapy or other factors. It was an open label study. Subjects knew that they were being treated, and physicians also knew who was being treated. There was no control group. At ECTRIMS, a second preliminary study was presented, a pilot study involving 16 subjects, but actually only 15 were enrolled. 8 received immediate angioplasty, and another 8 were to have delayed angioplasty at 6 months. All of these patients were found to have CCSVI before going into the study by Dr. Zamboni's ultrasound criteria. And then they were followed with repeat MRI, ultrasound, and clinical examinations for 12 months.